Hello my friends, this is Dr. Kazmi. You're watching my YouTube channel, and today we are going to talk about a very important subject, and that is the subject of blistering rashes in children. So often in the clinical practice as well on the exams, we do see cases in pediatrics which present with blistering rashes, and they usually become a diagnostic challenge because I have seen that most of the medical students as well as postgraduate trainees in pediatrics, they usually shy away when it comes down to have a differential diagnosis of blistering rashes. So that's why it's very important that we take a logical approach to diagnose blistering rashes, and we know of all those conditions which can present with blistering rashes in the pediatric age group. So without further ado, let's start our today's topic. So we will start with the definition of blistering rashes. Now a blister is a lesion, a skin rash, which is filled with clear fluid. So please keep it in mind that blistering rashes are rashes which are composed of a rash, which is a raised rash, and which is filled with clear fluid. It's very important that you should know that it is clear fluid. If it is filled with pus, then it becomes a pustule. So blistering rashes, most of the time, they would present with rashes which are filled with clear fluid. Now, again, they are further divided into two types. One is vesicle and the other is bulla. Now, if the lesion itself on the skin, the clear fluid containing lesion, if that measures less than 0.5 centimeter, then we call it as a vesicle. If it is more than 0.5 centimeters, we call it as bulla. So they are the same thing. It's only the size that differentiates between a vesicle and a bulla. But remember, both these two types of blistering rashes, whether it's a vesicle or whether it's bulla, it's always filled with clear fluid. Now remember that these bullae or these blisters, they can present in different types of conditions, and when we try to take a clinical approach for diagnosing these conditions, we see whether these rashes are localized or whether they are widespread. So remember that the vesicular lesion or the bullous lesion could either be localized. Localized mean that it is just confined to one particular part of the body, like it could be on the face, it could be on the one hand, or it could be on both hands, or it could be just on the leg. So this is what we call as a localized lesion of a blistering rash, whether it's vesicles or whether it's bullae. Sometimes you can get a combination of vesicle as bullae, but remember, if bullae are present, then obviously the rash should be classified as a bullous rash. But obviously, if they're all like small lesions less than 0.5 centimeter, then you will call it as a vesicular rash. So if they are confined to one particular part of the body, we call them as localized. If they are widespread, then we call it as a widespread, either vesicular or a bullous rash. So the classification, as I told you, is based on whether they are localized or whether they are widespread. And again, within localized, you have to see whether it is a vesicular lesion or whether it's a predominantly bullous lesion. Similarly, if it is widespread, again, you have to do a clinical examination to see if majority of the lesions are vesicular in nature or whether they are bullous in nature. So it's very important to see whether the first step, whether they are localized, and number two, whether they are widespread, and point number two is to see whether they are predominantly vesicular or whether they are predominantly bullous. Now, some of the conditions which are localized and they are vesicular in nature. So number one is friction blisters. Friction blister is very common, and it usually presents in neonates or infants who have got a habit of sucking their fingers. So if been, infants and babies, they are sucking on their thumb or on their fingers, so they can get blisters, friction blisters, either on thumbs or fingers, or sometimes even inside of the oral mucosa, especially on the upper or the lower lip. Now, while discussing these, different types of rashes which present either in a localized pattern or a widespread pattern, first of all, I would try to briefly explain the causes of these rashes, and then I would take you on a pictorial tour of all these types of rashes, where I would focus on the main differentiating points, so it's easy for you to diagnose these conditions when you are presented with these conditions either in your clinical practice or you are given these type of photographs in your MRCP-CH exam. So I was talking about friction blisters. Friction blisters are always there. They are usually localized, they are usually solitary or maybe one or two, and they are usually present in part of excess friction. So friction blister would be a suckling blister on the finger or on the thumb, especially in neonates and infants. It could also be present on those parts of the bodies which come in repeated friction. Like for example, school-going children who are wearing tight shoes, they can develop these friction blisters on the medial side of their big toe. They can also develop friction blisters on their heels if they got tight shoes, or sometimes they can develop on other parts of the body as well which come in friction. Like for example, those who are playing a lot, they can get their friction blisters on the palmar side of the metacarpal bones. So again, so where there would be mostly the friction forces, children can get friction blisters. So they are mostly localized. Another important cause of localized vesicular lesion is atopic dermatitis. So atopic dermatitis is also known as eczema, can present in two flavors. It could be either a localized or it could be either a widespread lesion depending on the severity of the condition. So in very mild cases, you might see a patch of eczema here and there on the body. Like for example, you might see in babies, you might see it on the face, you might see on the flexor surfaces. As they grow, then usually the pattern changes and they become more predominant on the extensor surfaces. But many times in mild eczema, you might see a patch on the chest or on the abdomen or on the face. So, and it can become vesicular in nature, though most of the times it would be a rough patch of skin because there is lichenification, but sometimes it can become, as a child is scratching, it can become vesicular in nature as well. So atopic dermatitis, and the third is contact dermatitis. Contact dermatitis usually happens when there is contact with something to which the child may be allergic. And most of the time when they, if they are allergic to different types of plants, when they come in contact with plants, they're going out in the woods or they're in the garden, they can develop a sort of a vesicular rash, and this is usually linear. So there's usually a linear pattern to it. So that you might find it on the back of the wrist, on the palm, or on the forearms, or usually on the legs. So it's mostly present on those parts of the body which are exposed to an allergen. It can also happen if you are allergic to different types of metals, and if you are wearing watches which have got different types of metals, or if you are wearing something like on a necklace made up of some metal to which the child is allergic, so they can develop a sort of a pattern, a pattern lash with small vesicles. So remember that contact dermatitis is an allergic type of dermatitis to different types of things to which a child may be allergic, and it usually happens in the exposed parts of the body or those parts of the body which come in contact with these allergens. Then insect bite. Insect bite can sometimes give you a localized blister. Sandflies, gnats, when they bite, and especially if they have got different types of toxic proteins in their bites. So usually the area where they have bitten can develop a sort of a blister, a localized blister, which is a painful blister. Then another type of localized vesicular region child can get in herpes zoster. So herpes zoster gives you a localized rash, but it's a very painful rash, and usually they get it in dermatomal pattern. So you would see there will always be sort of a pattern which is following a particular dermatome. So you might get it on the face in a dermatomal pattern, the child might get it around the neck, or they may get it around the abdomen, but you would always see that they are following a dermatomal pattern. Herpes simplex. Herpes simplex, cold sores as we call them, usually can give you sort of a vesicular rash around the mouth. So most of the time it is around the mouth, but it can be on any part of the body. And they are usually a group of small vesicles clear fluid-filled vesicles, which usually ulcerate, and they're quite painful. Then another cause of localized vesicular lesion is hyperhidroptic eczema. So this is a special type of eczema which is usually present around the fingers or around the extensor surfaces, and usually get very tiny vesicles filled with clear fluids, and they are quite itchy. So that is hyperhidroptic eczema. And then some of the immunological conditions like porphyria cutanea tarda. So this is a condition, a metabolic condition, in which a child can develop, though it's a rare condition, it's not very common, but if present, a child can develop rash, especially on the hands or on those parts of the body which are exposed to sun, because usually the rash comes up when somebody who has got this metabolic problem, they are exposed to the sunlight, and the ultraviolet lights actually irritates the skin, and they come up in a rash. So it's usually present on the sun exposed parts of the body, like the back of the hands or on the face. Then the localized bullous type of rashes. So most common is Bullish Impetigo. So impetigo is a streptococcal infection, sometimes can be even caused by Staphylococcal as well. And usually these lesions, they start up as clear fluid-filled vesicles, which usually ulcerate, and then they are covered with a honey crust sort of a scab. But remember that there is a bullous variety as well, and in bullous variety what would happen is that it's the same bacteria, but instead of causing honey crusting, it usually presents as a solitary or a group of large bullae, and the base is actually quite inflamed, and usually it grows very quickly and then usually bursts open, leaving a painful raw area. Linear Iga Dermatosis, which is again an immunological condition, and again a very rare one. I haven't seen at least one in my life, but sometimes you do get it on the exams in the form of a pictorial photograph where they ask you for the diagnosis. So linear Iga Dermatosis has got a very characteristic pattern. So you would see that if you have seen cases of erythema multiforme, the hallmark of erythema multiforme are target lesions, but they are macular target lesions. There is a sort of a central ring and clear ring, and then there is a area of surrounding inflammation, but that is macular. So if you get a targetoid lesion, vesicular lesion, or a targetoid lesion where there is a bulla formation, please keep it in mind that is pathognomonic of linear Iga dermatosis or linear Iga disease. So usually if you zoom into that picture, if you get in the exam, okay, and if you see that there are blisters or bullae formation, and that bullae formation is in the form of a targetoid lesion, so you feel like there is a target lesion, then you can clearly mark that as linear Iga dermatosis. So what happens in this condition, which is a rare condition, is that there are Iga antibodies which actually get deposited at the junction of the epidermis and dermis, and then that leads to severe inflammation, because a lot of your inflammatory cells, they come into that area, and that leads to the breakage between the epidermis and the dermis, so it leads to a tense bullae formation. So that area becomes either gets filled with fluid and presents the form of a blistering rash. It might be localized or it might be very extensive depending on the severity of the condition. Then you can have fixed drug eruptions, which are usually secondary to certain types of drugs, usually sulfonamides and tetracycline, then some other drugs, carbamazepine, and which can cause Stevens-Johnson syndrome. But there are different types of drugs which can give you adverse reactions in the form of what we call as fixed drug reaction. So every time somebody who is allergic to these types of drugs, when they take, so they would come up with a fix. Fix mean that it is fixed. Whenever you take, it's the same part of the body where the rash appears. So that's why it is known as a fixed drug eruption. So in a fixed drug eruption, there is usually a history of previous similar type of eruption in the same place. And usually the offending drug is more or less belongs to either the sulfonamide groups or the tetracycline groups. Now coming down to the widespread rashes, blistering rashes, which again can be divided into widespread vesicular or widespread bullous rashes. First of all, let's talk about the widespread vesicular rashes. So varicella or chickenpox is the most common. So usually in autumn and winter, when the chickenpox virus is in circulation, kids can get it. So usually they present with mild febrile illness, and usually on the third or fourth day they come up with this what we call as a characteristic dewdrop centrifugal rash. So there are crops of lesions here and there which are just like dewdrops, as you see the dewdrops on the petals of a flower, and they appear in crops. They appear in different stages. So you might get 1 or 2 lesions on one particular part of the body, and then after a few hours there are another one appearing on another part of the body. So some of them, then they burst open and they scab, the other they are in. So the rash would be in different phases. Some of those would be early lesions, some of those would be late lesions, but it's a centrifugal dewdrop illness, quite common in children, caused by the varicella virus. And the other type which is quite closely, it's similar in presentation to varicella, that is the hand-foot-mouth disease. So hand-foot-mouth disease, it's also a viral disease. It's called by the Coxsackie virus. And why we call it hand-foot-mouth disease? Because the mouth is involved, the oral mucosa is involved. It predominantly appears on hand, and it also appears on the feet as well. It doesn't mean that it doesn't appear on other parts of the body. You can have a few lesions here and there on the other part of the body, but predominantly you would be seeing that in hand, foot and mouth disease, the clustering is on the hands, on the feet, and inside the oral cavity. So it's also a mildly febrile illness and presents with rashes in the mouth, on the back of the hands, and predominantly on feet. Then widespread vesicular rash can also be a hallmark of incontinentia pigmenti, which is an X-linked dominant condition. Usually presents in girls. There is usually a history in the siblings and in the mom as well. So incontinentia pigmenti is a very complex type of an illness. The rashes, they usually follow the lines of Plaschko, and they usually go through different phases. So it can present as an hyperpigmentation followed by a vesicular rash, which then bursts open, can lead to a bit of scarring as well, and then there is hypopigmentation. So it can go in different phases, but it usually presents in the neonatal period. It's an X-linked dominant condition, so more common in girls. Then we have got Eczema Herpeticum, which is actually herpes simplex, florid herpes simplex virus infection on an eczematous base. So these are children who have got severe eczema, they've got severe atopy, and on top of it, because especially if they are using steroids or if their immune system is down, they can get a florid herpes simplex, widespread herpes simplex infection, because it's easy for the virus to replicate in the damaged skin, and that is what we call as Eczema Herpeticum. So it's quite a serious condition, and the kids, they need to be hospitalized, they need to be given intravenous cyclovir or other antiviral agents. Geonoty cross-T syndrome is another presentation of vesicular rash in early childhood. It's also known as acropustulosis of infancy, and mostly it presents with papular and vesicular lesions, which is mostly confined to the acral part, so it will be more on the feet and on the hand, but usually the spread is there on the rest of the body as well. And it's an idiopathic condition, usually happens after viral illnesses, and sometimes can just present as an idiopathic condition as well. Stevens-Johnson syndrome is basically erythema multiforme with mucosal involvement, where the less of 10% of the body surface area is involved, and if it is more than 30%, we call it toxic epidermal necrolysis, which is quite a serious condition. But even SJS is Stevens-Johnson syndrome, which is actually an immunological condition, usually happens secondary to use of different types of drugs like carbamazepine, sulfonamides, nitrofurantoin, etc. So there are different types of drugs which can sometimes rarely cause this Stevens-Johnson syndrome, and that usually children present in a very bad state, so it has to be treated as burns, and then you have to give them intravenous antibiotics to prevent secondary infection. and you have to give them IV fluids to hydrate them as well. Phytophthora Dermatosis are usually conditions by making Porphyria cutaneata, and it usually happens when kids are out in the woods and they are at the same time exposed to sunlight as well. So that can give them rashes, vesicular rashes on the sun exposed part, especially those parts which come in contact with different types of plants like hands and feet or lower legs. Now in the widespread bullous category, where you've got like lesions more than 0.5 centimeter in size, you can get it in what we call as the widespread form of Bullish Impetigo. So Bullish Impetigo usually present as solitary lesions. So you might get a sort of a big bulla on the chest or on the arm with a red base. It's painful. There is signs of infection at the base. But sometimes if the child has got a compromised immunity or something, you might get a widespread bullous rash as well. And that has to be then treated with intravenous antibiotics. Another condition is Epidermolysis Bullosa, which is again sort of an immunological conditions in which again it's of different types. I'm not going to go into details of Epidermolysis Bullosa simplex and dystrophy, and there is like so many varieties of that. But what happens is that there are usually there's an immunological insult which breaks the junctions either in the epidermis or at the epidermal and dermal junctions and leads to formation of spontaneous blisters. It usually presents in the neonatal or early infancy age, and it's quite a debilitating condition. The blisters, they pop open and that can lead to fluid loss, and it has to be treated as burns. Then the other condition are staphylococcal scalded skin syndrome, again a very serious condition in which what happens usually is that the child gets a sore throat or something which is staphylococcal infection, but what happens is that the exfoliative toxins from the staphylococci, they go everywhere in the body, especially in the skin, and then they cause exfoliation in the form of blistering. And what happens that these are very superficial large bullae which can easily be broken. Light pressure can just cause slipping of the skin, and they just present like burns, and they have to be treated with intravenous anti-staphylococcal antibiotics. And toxic epidermonecrolysis is Stevens-Johnson syndrome with more than 30% of the body surface involvement, and again that's quite a serious condition. So having talked about these different classifications of these blistering rashes, whether they are localized or whether they are widespread, again whether they are vesicular, whether they are bullous, let's go through a pictorial tour of the different types of rashes, where I would be talking about some of the differentiating points which makes it easy for you to diagnose or pinpoint the diagnosis if you are confronted with such a condition in your clinical practice, or even if you are given a pictorial sort of questions in your MRC-PCH part 2 examination. So let's start. So here I'll start. If you see this one, if I go here and so if you see this one, this is a friction blister. Why this is a friction blister? As you can see, it is a solitary blister. There is no surrounding inflammation. It is filled with very clear fluid, and it is present on that part of the body which usually comes in repeated friction. Like the toes are, especially if you are wearing tight shoes, so you will be having repeated friction on the inner surface of the shoe with the skin of your toes, and you can get blisters. So most commonly you either get it on your big toe or on your small toe, and here you can see a very crystal clear small friction blister on the little toe. Now if you look at this is a baby, an infant, and you can see there is a rash around the mouth. So you can see there is lichenification, though lichenification is actually felt if you put your hand on the skin, and you'll see there will be thickening, leathery thickening of the skin. But even you can see that there are small blisters and they are thickening of the skin around the perioral area, and then there is some around the eyes as well and some on the cheeks as well. So this is a localized form of what we call as atopic dermatitis, or in very simple words, eczema. These two, if you see these two pictures, so you can see here there is a small group of vesicles filled with yellowish fluid very close to one another and close to the lower lip as well, and here you can see some on the mucosa of the upper lip as well. So this is what we call as herpes simplex stomatitis, or the localized lesions of herpes simplex. So these are caused by herpes simplex virus type 1, and they are also known as cold sores. So usually they coalesce, so as they are forming they would usually get grouped together, and then usually they can burst open, leaving a raw surface which is very, very painful. And those children, especially if they got oral lesions, usually the parents say he's not drinking, he's refusing to take his feeds, and if you open the mouth you will see these sort of raw ulcers on the oral mucosa, or you might see these grouped vesicular lesions around the mouth. Okay, in these pictures, if you look at this lesion, so you can see that there are lesions, vesicular lesions of different sizes on the back of the hands. And this was a child who developed this rash when he was exposed to sunlight. He had an underlying metabolic condition, and this is what we call as the characteristic rash of Porphyria cutanea tarda. So Porphyria again has got different types. The Porphyria cutanea tarda predominantly presents as photosensitive rash, and usually when their hands or face is exposed to the sun, they usually develop a blistering rash. On this side you can see that there are groups of small vesicles, very tiny vesicles, very close to one another, and if you see, they are localized and they are following a pattern. So you see here they are following a dermatomal pattern, and they are quite painful. So again, this type of rash is usually preceded with a lot of pain in the concerned area, and then usually after a few days the rash appears, and this is the rash of Herpes Zoster. Here you can also see this is again a Herpes Zoster rash, but this is in the what you call the distribution of the trigeminal nerve, and again it is following a dermatomal pattern, small vesicles here and there, quite painful condition. It causes burning pain. This is Herpes Zoster. Here you can see very deep, tense, small blisters on the sides of the fingers, and this usually happens in people who have got a history of eczema, and we call it hyperhidrotic eczema. So this is usually present along the borders of the fingers, and they are deep, small, tense vesicles. Here there are pictures of the baby. Again you can see a blister on the index finger, and here you can see a blister on the upper lip. These are solitary blisters, localized one, and these are caused by suckling. So these are suckling. So suckling is, blisters are actually a type of a friction blister. Okay, further moving on, here you can see this is very characteristic lesion of impetigo. So impetigo causes small vesicles which then rupture, followed by honey colored incrustation, especially more common on the face, but here you can see that solitary lesions can appear on other parts of the body as well. So you see here there are two blisters, one bullous and one probably vesicle, rather both seems like probably bullous in lesion. There is another small one over here as well, and they have probably popped up, leaving some inflammatory raw base, and this is what we call as the bullous form of impetigo. So you can see the localized form of bullous impetigo. Now here, if you look at these lesions, if you just zoom into these lesions, you see these look like targets. The only thing is that these targets are bullous in nature. Normally if you get macular targets, they are quite what we call pathognomonic of erythema multiforme, but here you see they are blisters, widespread blisters on the hand, on the back of the thighs, on the face, on the lower legs, even in the perineal region, and they are characteristics of what we call as linear IgA dermatosis. So linear IgA disease or linear IgA dermatosis, no matter whatever it is called in different books, it always presents with a blistering rash, which might be localized or it might be widespread, but the hallmark is a target shape bullous or vesicular lesion. So if in a picture, an exam, you are given a lesion where there are blisters, but the blisters are in the form of a target, and in the choices you should pick up linear IgA disease. Then here you see a child who has got a vesicular rash, which are appearing in crops. Almost it's a widespread, all of the parts of the body are affected. You see some of them, they look like drops of dew on the petals. So this is chickenpox or varicella. On the right side, if you see, this is a child which is almost showing the same type of disease. You can't see much difference between this picture and this picture. The only difference is that here on the left side, the whole of the body is involved. See, the face is involved, the trunk is involved, the peripheries are involved. But here in this child, you see there are lesions around the mouth, small vesicles. There is one inside the mouth as well. And then there are lesions predominantly on the sole and on the hands as well. So this is hand, foot and mouth disease, hand, foot and mouth disease, which is called by Coxsackie virus, and it's a self-limiting viral condition, quite common in the European continent. Then moving on, here you see on the upper left side, if you see, this is the hand of a newborn, a child who has got bullous lesions. And these bullous lesions are, some of them are serpentine, in shape. Some of them are irregular, and they are following weird sort of, geometry. And we call them the lines of Blaschko. Usually these are the lines, in which during the fetal development as the skin is developing. So these lesions, they follow usually the lines of Blaschko, and they go through different stages. So like for example, in this case, you see there is a predominantly vesicular lesion, and now here you see it's healed with keloid type of scarring and hyperpigmentation. So this is an X-linked dominant condition. I told you earlier, this can go through different stages. We call it as incontinentia pigmenti. Incontinentia pigmenti. Now the lower two pictures, these are kids who have got atopic dermatitis, or as you call it, eczema as well, and on top of it, especially if they are using steroid or something, they can get a florid widespread herpes simplex infection on top of it, and we call it as Eczema Herpeticum. So you can see Eczema Herpeticum with vesicular lesions as well as bullous lesions. You can't see it because most of these lesions have burst open and leaving raw surface behind, which can get secondarily infected. Very painful condition, very dangerous condition, because they predominantly can lead to sepsis, and they need intravenous antibiotics and intravenous antiviral as well. This is another picture of Eczema Herpeticum, a child. Usually these pictures are quite often given in the MRCPCH Part 2 AKP exam. Usually a child who has got this type of lesion, they might give you a photo of the face, or they might give you a photo of the hand, but usually what you would see that there is an underlying base, eczematous base. So you would see some area which is inflamed, and on top of it you will see vesicular lesions, many of which would have burst open, and this is quite characteristic of Eczema Herpeticum. Okay, now if you look these conditions, okay, so here is a child who has got papular lesions. Some of them have developed into vesicles as well. So predominantly papular lesion with few tiny blisters as well. So you see it's mostly present on the hand, but it's also present on the forearm. It can present on the legs, especially extensor surfaces. Here you can see it's widespread. This is what we call as Geonoty syndrome. It's also known as acropustulosis of infancy. So in this, usually it's an idiopathic condition, or usually develops after some viral infection. The exact reasons are not known. It's a self-limiting condition, can stay for a few weeks, but what happens 2 to 3 weeks after a viral infection, or sometimes even after being bitten by insects, a child can develop a florid rash, which is usually in the form of papules. Some of them can be quite itchy as well. Some of them they develop into vesicles, and they can be present on the back of the hands, they can be present on the forearms, they can be present on the lower limbs as well. And it's a self-limiting condition, no treatment is required. But remember, it very much resembles the hand, foot and mouth disease. But remember, what differentiates it from hand, foot and mouth is, number one, the hand, foot, mouth is more limited to the hand, feet, and obviously there would be mouth lesions as well. But in Geonoty cross-stitch syndrome, you don't get oral lesions. So that is one differentiating point when you are trying to differentiate it, or if you are confused that whether it's hand, foot, mouth or whether this is Geonoty cross-stitch syndrome. So Geonoty cross-stitch syndrome is more florid as compared to hand, foot, mouth disease, and there is no oral involvement. So always keep this in mind. And my last slide is, if you look at this child, okay, which has got, it feels like the child's skin has been burnt. Okay, and many people might mistakenly take it as for sort of a non-accidental injury, because non-accidental injury is another thing which is usually tested in exams as well, and usually in clinical practice in UK as well, we have to take this in quite seriously, and we have to keep our suspicions high, especially if the history is changing, or if the family is known to the social services, or if the child has been on the child protection plan, or is a look after child. So there are different things by which you can have an idea where you can be suspicious of non-accidental injury. Now obviously, if you look at this, you see they're bilateral, they're very clear cut demarcation lines. So one can mistakenly take it as an immersion scald injury as well, which is a non-accidental injury. But in this particular case, this you see there are large blisters which have popped up, leaving up a raw surface, and this is a case of Epidermolysis Bullosa. Here you can again see the blisters being formed, a lot of fluid, and they usually, when they pop open, they would leave a raw surface, and this is a very debilitating condition. Presence at the time of birth, it usually presents in neonates, and it's got different types. So this is Epidermolysis Bullosa. Differential diagnosis is with non-accidental injury and with burns, but again the history can differentiate between the two. And last but not the least, if you see the last photograph over here, so you can see a big or you can see large bullets which have just been denuded, okay, and they have popped open, leaving raw surface behind. This is Staphylococcal scalded skin syndrome. Usually starts as a staphylococcal infection in some part of the body, and after a few days the exfoliative toxins just like spreads in the whole of the body and causes bullets in different parts of the body. So if you try to culture the fluid from these bullets, you won't find the staphylococci themselves, because it's not the staphylococci themselves which is causing, it's the exfoliative toxin which causes that. So this is staphylococcal scalded skin syndrome picture. So this in a nutshell was an approach to blistering rashes in children. So once again, just to summarize all this, please keep it in mind that blisters are small lesions, skin lesions, which are filled with clear fluid. If they are less than 0.5 centimeter in size, we call them as a vesicle. If they are more than 0.5 centimeter in size, we call them as bullae. Again, we have to see whether it's a predominantly vesicular lesion, whether it's a predominantly bullous lesion, then again whether it's localized or whether this is a widespread. And on the basis of that, then there are different types of causes for these lesions. It's usually a pictorial diagnosis. You have to look and you have to practice with these pictures. You have to see it again and again, and understand the underlying pathology as well. And then it's easy for you if you come in clinical practice, if you come across such cases in your clinical practice, or if you are given photographs in the exam, it becomes easy for you to diagnose. So practice is the key. There are different types of atlases, photo atlases online, which can be consulted to get an idea how these types of rashes, blistering rashes, they appear, because again it's not necessarily that they would present on on the same spot in every case. These type of rashes can present in different parts of the body. Every individual is different, so the presentation can differ from case to case. So if there are any questions, queries, you can just put down in the comment section below, and I will get back to you and answer all of your questions. Thank you very much and have a good day.